Hello, welcome to 619 Professional Issues with ABA group debate. Our group debate topic is alternative models to address quality of care for children with ASD. The three common theoretical perspectives of treatment for individuals with ASD that we're going to cover today is the medical model, sensory integration model, and ABA model. So I'm going to introduce everyone. So I'm Anita. I'm going to be the introducer for this debate. I research sensory integration model. Tiffany will be the summarizer, and she researched the ABA model. Carol will be the illustrator, and she has researched the medical model. Tiffany, Carol, and myself, all three took on the roles as researcher and fielders and summarizers. We created the pros and cons for each of our individual researched model of treatment. We've chosen to use an informal structure of debate, so the primary researcher will introduce their respective model of treatment, as well as the positive aspects of utilizing that model as a treatment for ASD. The other two members will be participating in the counter side of that model. I'm going to now pass the direction over to Carol, who's going to introduce the medical model.
According to Myers and Johnson in 2007, the targeted symptoms for children with ASD were repetitive behavior, behavioral rigidity, obsessive-compulsive symptoms, hyperactivity, impulsivity, inattention, aggression, outbursts, self-injury, sleep dysfunction, anxiety, and depression, including irritability, sadness, crying spells, decreasing energy, anorexia, weight loss, and sleep dysfunction. The two primary components of the medical model that I'm going to be addressing are the pharmacological treatments and the complementary and alternative medicine treatments. In terms of the medical treatments, pharmacological treatments can lessen the effect of the emotional and behavioral problems in people with ASD. One of the choices that they use is the selective serotonin reuptake inhibitors, which is also called SSRI. These are prescribed for anxiety, aggression, self-injurious behavior, and/or obsessive-compulsive disorder. According to Amen et al. 2003, the older a person is, the more prevalent the use of psychotropic drugs, although the exact reason for that is unknown. And another contributing factor is living outside the home was associated with the greater use of mood stabilizers and sedatives. Continuing with the treatments, we have the older antipsychotic medication, also known to be effective in treating problems, and they may be effective in treating serious behavior problems. The newer atypical antipsychotic may be better choice for children. Risperidone is shown to reduce tantrums, aggression, and self-injurious behavior in children with autism. Usually considered for us only after a behavior management program or for use only after a behavior management program has failed. Anticonvulsants are also used in the medical industry with medical treatment to treat seizures, and stimulant medication is used to treat the attention deficit or attention deficit hyperactivity disorder. Also, in this medical model, they use lithium to help with aggression, and the using medicine to treat symptoms can improve the quality of life in individuals and their families. In terms of the second portion of the medical model is the complementary and and alternative medicine, and this allows the treatment of disorders without some of the specific side effects of the medical model. Classifications with the complementary and alternative medicine includes mind and body therapies, biologically based practices, manipulative and body-based practices, including chiropractic and massage therapy. Some of the most common treatments for the complementary and alternative medicine are music therapy and yoga. Some of the biological-based practices include melatonin, vitamin C, multivitamins, gluten-free and casein-free diets, which there is much more research needed on the efficacy. Discouraged treatments are chelation therapy and the hyperbaric oxygen chamber. Also included in this is manipulative and body practices, which can include chiropractic, craniosacral manipulation, massage and therapeutic touch, and acupuncture. And now we will do the counterpoints for this. That goes over to...
So the counterpoints for the medical model are that pharmacological treatments have not been effective in treating core deficits, such as social deficits. Are also age restrictions on medications, clients or patients have access to all of the medications. There are side effects that are not limited to abdominal discomfort, fatigue, headache, and dizziness. Parental warnings to watch for signs of suicide as a potential side effect. For efficacy and long-term effects are in their early stages on use of medical model. Side effects of sleepiness, tremors, and weight gain also exist. Patient must be closely monitored by a physician. Side effects are prescribing off-label medications for purposes other than what they were approved for. Side effects can include appetite reduction, inhibition of growth, jitteriness, abdominal discomfort, increased blood pressure, increased heart rate, irritability, increased anxiety, and repetitive behaviors. Another item for consideration is that regular blood tests are needed to monitor the treatments, and long-term use of these medications may cause metabolic and congenital adverse effects in some people. And lastly, more controlled testing is needed consensus on the evidence-based approach to medical interventions. And now we are going to turn it over to Anita for the next part.
Okay, so I'm going to talk about the sensory integration model. It's commonly reported that sensory integration can help facilitate improvements in focus, language, and social behaviors. There are numerous reports from occupational therapists and families of it being a successful treatment for the individuals that they work with. The thing is that sensory integration occurs with all of us. Neurotypical or not, we're all sensory beings, and we all have a different sensory need. So a big goal with sensory integration is finding the balance within the individual sensory system. Ideally, we want to be calm and alert within our environment. So some people have sensory systems that would benefit from activities to promote alert behavior, whereas some have a sensory system that would benefit from activities promoting calm behavior. These needs can change multiple times throughout the day. So for example, in the afternoon after having lunch, we tend to have more activities promoting alert behavior to keep us alert and active in our environment. So you're going to see here on our next slide, it's going to show the article of Walting and Hauer. And within this article, there's some sensory features that are mentioned being present that more than 80% of individuals with ASD engage in some of these sensory features. So some of those are hand flapping, spinning, rocking, ear covering, withdrawal, intense staring. Over the years, there's been an increase in attention given within research of these sensory features. Sensory integration intervention comes from Ayers sensory integration, and it's defined as a play-based method that uses active engagement, social rich activities to elicit a child's adaptive responses. It improves a child's ability to successfully perform and meet environmental challenges. So therapists use specifically designed equipment that is customized for that particular child. So the activities and everything are custom made for that child and their challenges within their sensory processing and motor planning and problem solving. One of the most common assessments used for identifying this is called sensory profile. So this profile assists in selecting appropriate activities that the individual and their specific sensory profile highlights. So you can see on this next slide, the 7 senses. We have that next slide. Do you guys see that next slide?
No.
No? Okay. Well, on this next slide, we have set our 7 senses. Would it be here? That PowerPoint?
I see it.
There we go. Okay, so here you see our sensory senses. So you've got the most common that most people are familiar with are sight, sound, smell, taste, and touch. However, there are 2 more that are common in our systems that we don't always talk about. So that's proprioception and vestibular. So proprioception is about more with our muscles and joints and body awareness, whereas vestibular, we'll go back one more with that slide. Vestibular is more about the what's going on in the inner ear and how we react to different movements. Are we getting dizzy in our environment? Things like that. These things are very important to take into consideration when selecting strategies for children with ASD. So when creating competing behavior pathways and appropriately identifying alternative behaviors that provide the same function for that individual and that particular sensory need or seek or avoidance. So let's have a look at the next slide that demonstrates the pyramid of learning. So this impacts our sensory processing of learning. So there at the bottom, you see we have our central nervous system, and we have I'm not sure what's next. So we've got our tactile, our sensory systems are at the bottom of this pyramid on that next slide. And at the bottom, we need to, it's like our foundation. So we need to have that foundation for the child to be successful in the academic environments, which are kind of the top of that pyramid. So if you look at the top of the pyramid, you'll see there's going to be academics. So reading, writing, math, you're going to see spelling, you're going to see speech, and all of that is above the sensory systems. With those sensory systems below, the child is going to be struggling in those academic areas above. So it's important that we find a way to build up the processing and kind of coordinating our sensory systems. So, sorry, I lost the instruments. So that's the foundation at the bottom. So with that, if you think about this, so I'm reading my notes now, right? So that I'm integrating two sides of my body to read this information. Now, it would be more difficult for me if I had deficits in some of my sensory processing in those lower domains on that learning pyramid. Okay, so as research continues to attempt at showing sensory integration as an effective intervention, a common difficulty is how to measure some of our sensory systems. So this next slide is the article Shosting and Hart et al. 2015. And this is fielding a way to measure and test and evaluate proprioception in individuals. So this works on processing information from our muscles and joints, as well as body awareness. There is an instrument that's being used now to test the force and touch emitted by individuals carrying out specific tasks. So the instrument within this, it collects data on real time. So you're going to do, the child will do an activity, and with that, they're collecting real time data on their force and touch and their proprioception. And this, so this shows that research and development within technology advancements are creating tools to assist in making our sensory systems more measurable and observable. So in line with being a good behavior analyst, it is important to continue to seek professional development opportunities and stay current with the research. So over time, we have to change our decisions to meet the demands of ever-changing culture values, contingencies, staying current with best practice and research, as well as continuing to focus on social validity. Sensory integration could be on the list in the near future and should continue to be looked at and considered by professionals where appropriate, as research is really showing ways to measure and really collect data with those sensory systems. So now I'm going to pass it over to Carol. She's going to counter the research on sensory integration.
As behavior analysts follow the professional ethical code for behavior, it clearly states in code 2.09 that that individuals have the right to effective treatment and that there is a responsibility to scientifically supported treatment. Some of the competing professions have theories that they use as strategies for individuals with ASD. However, these are not necessarily proven to be effective. Sensory diets are one of those treatments. As behavior analysts, we do not necessarily condone the approach, but we don't necessarily need to implement the strategies either. We may work as part of a multidisciplinary team and respect that profession, but as behavior analysts held to an ethical code, we don't necessarily implement the techniques if it conflicts with the behavior plan. If the recommendation within a sensory integration diet or treatment conflicts with the individual behavior plan, it is unethical to implement the sensory integration. However, as a behavior analyst, we may advocate and collect data before, during, and after a sensory diet to state a case in favor of or opposing the SI model. There is limited positive research within the SI model. According to Lang, O'Reilly, Healy et al., review title, Sensory Integration Therapy for Autism Spectrum Disorders, a Systematic Review. This article reviewed the findings and outcomes of 25 studies. Of the 25 studies reviewed, 3 studies suggested that SIT was effective. 8 studies reported mixed results, and 14 studies found no benefit to sensory integration therapy. Although 3 studies did find SIT to be effective, the marginal difference is significant. The review demonstrates that there is no benefit to any participant, but it does not necessarily show that there was harm. The concern is the treatment effective? At this time, there is not enough evidence to demonstrate that SI is an effective treatment. There needs to be more research conducted, as well to needing further research, the strategies used to be individualized to the learner, and that is not always clear within the research. For example, this review showed that when there was no improvement found with the SI model, the strategies used was solely the use of a weighted vest. There is a need for validity within the assessment of need and identifying the areas of deficit within sensory processing prior to implementing the strategies. Not all children would benefit from a weighted vest, but it was commonly the sole strategy implemented in conjunction with brushing. Some researchers have demonstrated that SIT may accidentally create an increase in problematic behavior. SI often allows individuals significant access to enjoyable activities, attention, and breaks for demanding activities when problem behavior occurs, which would increase that problematic behavior. Note that if it was in fact true and causes an increase in problem behavior, it would be an ethical concern for the individual's right to effective treatment, 209A, and would want to do no harm and benefiting others. Caution should be used when using SI as a treatment model until further research can be conducted. Now to Tiffany for ABA.
Okay. So I am going to first talk about ABA, what it is. It is applied behavior analysis, and it is described by Bailey and Birch, 2016, by being B.F. Skinner's work on behavior in the 1950s, which laid the foundation for current applied behavior analysis. It began to take shape in the 1960s. Analysts, who were pioneers in the field, Baer, Wolf, and Risley described behavior analytic principles that the technology of ABA is founded on for today. Abuse and scandal about ethical treatment and clients' rights warranted the formation of standards for the field. And in 1998, Kochert and Keith Spiegel laid out 9 core ethical principles for guiding psychologists in their ethics, and those 9 core principles were adapted for the ABA field. Additionally, a governing body of behavior analyst certification board was established to oversee those working field and to have checks and balances within the profession. And ethical compliance codes for behavior analysts were created, and guidelines that behavior therapists are expected to adhere to through that governing body. First point for notion of ABA is empirical evidence. Empirical evidence is information gained by collecting data from observation or experimentation. It is evidence to support ABA in the form of conducted studies and published results. Some of the studies that are to support ABA's use are Fox in 2008, who lists over 1,000 peer-reviewed articles describing success in ABA treatment at the time the article was published. Stanislaw, Green, Sparkman, and Cohen in 2014 report clinical success with ABA treatment in the form of children scoring in the normal range in cognitive, language, and adaptive functioning following treatment. Walsh in 2011 listed listed that it was reported that 40 to 50% of children with autism can return to the mainstream after ABA treatment skills. Prezant in 2009 reported that the National Research Council showed substantial changes in children receiving ABA intervention. Grand, Pisha, Tarbox, and Dixon reported several hundred single case experiments and a growing number of between group studies showing success in the uses of ABA treatment that the article was published. Additionally, there's a growing number of endorsements for the use of ABA in the treatment of autism spectrum disorder. Those endorsements are as follows. The New York State Department of Health recommended ABA as a treatment for autism, and they did not recommend auditory integration, floor time sensory integration, or other interventions. In general, as well as the National Institute of Mental Health funding research on ABA, as reported by Fox. 2011 reports that the Canada's Ministers Autism Spectrum Disorder Reference Group endorses ABA, and ABA is provided for in the Department of Education and Policy in Ontario. Grand Pisa et al. Lists the National Academy of Sciences and the American Academy of Pediatrics also as endorsers. The next point is that treatments for ABA are based on scientific findings. I'm going to show that slide in just a second. Treatments for ABA are based on scientific findings, and Green-Pisha et al. States that ABA is based on the behavior principles of learning established by B.F. Skinner, and that consequences to behavior either strengthen or weaken it. So those are the founding principles that ABA is based on in behavioral science. Let me get that slide up for you. Bailey and Birch show that the Code of Ethics for Behavior Analysts states that ABA treatments must be used that have the best research to support their use and their findings and their results. Fox states that ABA meets the scientific burden of proof and follows all the principles set forth for effective treatment of ASD and incorporates all factors identified by the U.S. Council as characterized by Okay, so this slide, that there are a variety of treatments tailored to the client's needs. This is a chart from Dylan Berger, and it just shows all the wide range of can be encompassed in the ABA treatment overhead. The next point for the ABA model is that it is a client-centered approach. It means that focus of the intervention is on the client and their well-being, and is taken into consideration of importance. That Prezant states that contemporary practices in ABA are person-centered. Birch described the Code of Ethics requiring input and consent from the client in regards to testing, to treatment, implementation, and program change, support of family and input of client, this type of a model. The family goes a long way in helping to and promote and carry over the intervention in the home. That is also of great importance. Fox lists parent training as a component to make ABA successful and encourages their participation, parents' participation, as well as encourages the choice making and problem solving by the clients, so that the participant in the process. So another way to say that the client-centered approach is on my next slide, which is so this signifies that they want to make sure that the client has the most say in the process, and that they are involved in the process and have a choice in what happens to them or with them. Lastly, Walsh describes the use of ABA to support independence and increasing confidence in self-advocacy, and having the client participate in decisions such as type of rewards used to foster success. If your client is able to tell you what kind of reward best motivates them, then that is going to be your most likely way to get them to comply and participate in the treatment and have it be most effective. Point for the ABA model, utility. So I will get that slide of that. I just mean, when I say utility, it is useful. There are many different ranges of behaviors that can be treated with ABA. There are many different settings that it can be used in, and there's a wide range of clients that would benefit from such things. Flexibility is key when you are using the ABA model, and is one of the driving features of ABA. Oh, there's my slide. Utility, my toolbox. So the reports that there's use with bedwetting and social skills, gameplay, and grocery shopping. Another report by Fox uses ABA with feeding and language, and Ranpisha et al. Reports the use of ABA in more severe behaviors such as self-interest behavior, aggression, and property destruction. These are all fall under the umbrella of being able to be treated by ABA. And the next one is the next ABA can be used in all age ranges. Bailey and Birch and Present note that a variety of settings has been utilized, have been documented, and in that can be used, ABA can be used in a variety of settings that you wouldn't necessarily think, aside from school-based and clinical interventions. They can also be used in social situations and outside in the greater community, as far as in businesses, and to support individuals with autism at their jobs so that they can be gainfully employed. The ABA is able to build skills, new skills, add new skills onto the repertoire already established. So this is helpful in establishing or reducing problem behaviors in social and educational areas where repertoires are needed. To say that ABA is fluid and can change and grow with the needs of the client. That being said, this is important in a social dynamic, as social situations cannot necessarily be predicted. So being flexible and using the principles of ABA that are taught help with that social situation piece. Bailey and Birch also point out that ABA can be used in conjunction with other therapies, disciplines such as speech, OT, and PT. The next point, support of ABA, is time considerations. The last point is time considerations. Time is of utmost importance. That is what Bailey and Birch state, that based on the Code of Ethics and Behavior, analysts can adjust hours of therapy to reflect the client's changing needs. And Grandpisha et al. reflect this ability of ABA to be flexible on therapy time. You can have more hours or less hours dependent upon the client's need. The client, once again, back to the client-centered model of ABA, this is also ties into that of being flexible of the time for therapies. Walsh states the importance of ABA for in-the-moment situations to maximize outcomes where time is of the essence, such as tantrums, job-specific behavior issues, or social situations. Fox points to potentially quicker outcomes with the use of ABA instead of trying to find the right balance or dosage of medication strategy, which can be very costly time-wise. And then I will turn over the presentation to Anita, who is going to present some counterpoints.
Okay. So some of the counterpoints for ABA model. Some people say that it can be robotic, mannerisms and speech. It's kind of repetitive and it isn't very naturalistic. There's also an issue with that ABA can be time consuming and it requires a set number of hours per week. And it can be pretty intensive for a family to implement. It also requires a huge commitment on the part of the family to ensure carryover and generalization. So it typically requires everybody to be on board, grandparents, babysitters, neighbors, everyone in that child's environment, which can take time to do the training across the board, across all the people in the family. So that can be kind of a negative side about it. It also causes the clients to become more reward dependent. So they're not always going to find things naturally rewarding. They may be dependent on tokens or things like that. I know that over time it is ideal to do, transition to natural reinforcers in place of the secondary reinforcers. ABA is also expensive. It can be costly for the family to implement, and them knowing that this is an effective treatment and that the parents need to spend so much money to get their child the right services. That can be pretty stressful for a family dynamic as well. Also, it isn't ethical to use ABA to try to fix individuals with ASD. Sometimes we're hearing that ABA is the cure or it's to fix the child with ASD. So this is kind of a negative aspect that can be seen. ABA also uses aversive therapies, which are ethically questionable. So this is sometimes a misconception with ABA, is that it's aversive or that they're strapping children to chairs, which is untrue of that. So the issue is addressed in the Code of Ethics, Ethical Principles of Behavior Analysis. Code 4.08, as described by Bailey and Birch, states that other therapies are attempted to first before aversive therapies. And if aversive therapies are warranted, it's mostly for self-injurious behavior, aggressive behavior that results in harm to client or other well-being. It is not the only intervention in place. There must be other reinforcements of alternative behaviors in place if you are using more aversive strategies within punishment. Baiting is required for safety checks in regard to the competence level of those administering the program, frequent review of the program, and removal of the aversive therapy when it's no longer needed is also important when following this Code 4.08. Now we're gonna transition to our Q&A portion. So our first question from our fielders is more commonly used as treatment. So I'm going to answer this. I'm going to go ahead and answer this question. So the initial model that typically gets visited is the medical model, and then often is sent to sensory integration or speech therapy kind of model. But we typically start in the medical model with the pediatrician. However, as an effective treatment, ABA is most commonly used, or at least tends to be the model used that is sustainable over time and shows the most benefit. Next, our next question that is, can the models be used simultaneously?
And I'm going to go ahead and take that question. The models, for the most effective treatment, eclecticism, which is the use of multiple models at once, is not recommended, as it shows not to be effective. Fox has research on this, as well as Howard, Stanislaw Green, et al. And when compared with other aspects and other models, ABA in certain studies showed greater gains, not the models or not the groups that took on more than one type of intervention at a time. The ABA groups were better than the eclectic groups as far as gains and as far as results.
Okay, good. The next question is one more effective at showing desired outcomes than another? You just answered that one, yeah.
Two, again, Fox states that only interventions to show comprehensive, lasting results on ABA principles. So the answer to that is that yes, one is more effective at showing desired outcomes, and that is ABA.
Okay, good. Our next question here we have is, which model has more evidence to support it?
I'll take that one. As Tiffany definitely showed us, the ABA has the evidence to support it, has the most evidence. More empirical data to support ABA, and ABA was founded on that on the empirically based treatment. So it's very clear that the evidence to support that is in favor of ABA.
All right, so our last question here we have is, if you were to choose a model for treatment for your child, which of them would you choose?
I'll take that one as well. I would base it specifically on ABA. However, I do believe that there is a place for the other therapies, maybe in a lesser role. There may be a place for the student to be on some medication, depending on what their comorbid conditions are. And there may be a way to incorporate the sensory integration portion of it as well. But the main focus would be on the ABA, but I think each of those other sensory and medical, I believe, have a place too, just not with as strongly as the ABA.
Mhm. Good. Good. So next we're going to do just a quick summary of each of our models. So the first model, if you could do a little summary.
Just based on the medical model is based on two different, the pharmacological and the complementary and alternative medicines. And the pharmacological aspect of it is the drugs that are prescribed for the treatment of symptoms of autism, especially the self-injurious behavior, etc. And the complementary and alternative medicines may be for parents who want to have a therapy but are afraid of the symptoms, such as the moodiness, or afraid of the symptoms that may be a side effect of the medications that they would put their child on.
Mm-hmm. Okay, good. I'll go with the sensory integration model. I do think there's a time and place for sensory integration. There isn't enough evidence to really show that it's an effective treatment and should be necessarily a go-to treatment for individuals with ASD. But it does sound like there's some research that is happening that might be showing some strategies that are effective. We are all sensory beings, so it does talk about how we all have different sensory needs, and those things should be taken into consideration when choosing interventions for that child and selecting replacement behaviors within your behavior treatment plan and alternative functions of the behaviors. So I do think there's a place for identifying some or paying attention to some of those sensory needs, but for sensory integration, I would say is not an effective treatment to be used with our list with ASD individuals. Okay, next we can go to the last model.
So that's me in the ABA model. ABA has a lot of evidence to support its use in individuals with ASD. The treatments in ABA are based on scientific findings and principles based in scientific origin. It is a client-centered approach, so the focus is on the client and their well-being and what's best for them. Utility, so it can be used in multiple settings with multiple clients for many different types of behaviors. The last point for is time considerations. Time of therapy can be adjusted up or down depending on the needs of the client, and the ABA can be used in the moment to some of more serious behaviors, behaviors that warrant immediate action, and they also can
Good.
So I think that this will conclude our debate. Does anybody else have any closing remarks?
No.
I don't. I think it's good.
Okay, so I'm just going to go ahead and share our, and then I will be concluding. this is the final page of references. And that's it. So this concludes our debate. Thank you, everybody, for watching.